Okay, Lukas, thank you very much for this very interesting presentation, interesting data. Are there questions from the audience over there?
Very good presentation, Lukas. My interest in this study, the first time I saw it, it really replicated an old, very old study since 1981 by Jeffrey Katz, where he used an esophageal catheter in postoperative patients. And interestingly, what struck me the most was that the distribution of the patient was exactly the same as you have. And the interesting question that he, in the discussion, he said that probably this is the PEEP, which gives, is close to the physiological FRC of the patient. And he made the usual implications on that. But what is your take on that? I saw that you have nothing in the discussion regarding this.
Yes, you're right. You're completely right. And that's what we think as well. That's restoring the FRC is probably what we do with this titration, or with the patient is just most efficient in his breathing when he goes back to his normal condition. That's what we think it is. But certainly we did not reproduce it so far, and we're just looking forward for anybody else to reproduce the data and see and measure the FRC, for example, and measure the different components of the respiratory mechanics to differentiate which component is affected by changing the PEEP and which actually causes the results.
Dr. Slatsky.
Lukas, a very clear presentation. One question for you though, and that the implication is that the place where you get the most efficient neuroventilatory coupling is the best PEEP. Can you just talk about that a little bit? I mean, what would be the mechanism? I mean, why should that be the best PEEP? This PEEP affects a lot of things, right? So the neuroventilatory coupling is just one aspect, and so it's most efficient, great. But why should that lead to better outcomes potentially?
Well, best PEEP is probably the PEEP which results in lowest cost of breathing and best oxygenation and least impairment of cardiac function. Let's put it this way. So what we presented here is just one aspect of best PEEP. It's just related to breathing efficiency. And we just left out the other components, which are equally important. So I think the box is wider than just looking at the breathing efficiency. But I think that's just a new or a probably equally valid way to look at best PEEP and to take into the equation. Because if you use too much energy actually to breathe, you will use up some of your oxygen that was generated or distributed, and the equation doesn't hold by the end of the day. So I think if the cost of breathing are lowest and the oxygenation is optimized and the effects on the hemodynamic systems are low as well, so that's probably the PEEP that results in best outcome for the patient.
So it's a combination of it's much more complex.
Yeah, I think so.
Just a small comment and question to you. Some of the patients did not have reproducible values when it went up and down with the PEEP. I mean, some of them had the same, at the same PEEP level, the highest efficiency, but others didn't. So what's your take on that?
You mean during the decreasing and the increasing part? Yeah, that's true. Most of them actually had the same, resulted in the same, but some did not. So that's very much possible that we de-recruited part of the lungs and could not recruit them during the stepwise increase in PEEP. I think it's related to mechanical factors that were different between decreasing and increasing part of the study.
Did you look at those patients in terms of the mechanics?
No.
Please.
Just a small follow-up question after Dr. Slatsky. question. Do you monitor oxygenation at the various PEEP levels? Did you find that at the best neuroventilatory efficiency you had probably better oxygenation? Did you try to make any such combination?
That's a good comment. We looked at the oxygenation, it didn't change overall. So we did not change the FiO2 during the study, and the oxygenation, there was no change over time in the oxygenation. So, but definitely we did not look at oxygen delivery, which would be more important, or SVO2, for example, so mixed venous oxygenation, what we heard today from Yuka, would be much more interesting to look at. We just looked at SPO2.